Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms, Marcus at Home welcomes Dr. Greg Marcus in San Francisco, California, with whom we would like to discuss the impact of alcohol consumption and coffee intake on patients with paroxysmal atrial fibrillation. Greg, it's a pleasure and an honor for us to have you tonight. Thanks for being our guest today.
My pleasure as well. Thanks so much for the invitation.
Dr. Marcus is a cardiac electrophysiologist, and he's professor of medicine at the University of California, San Francisco. And he has presented in the last year at least 3 landmark studies that answered the question in how far, on the one hand, coffee intake, on the other hand, alcohol consumption will cause arrhythmic episodes in patients with paroxysmal atrial fibrillation. So we plan to go through these papers step by step or paper by paper. And my co-moderators today are Florian Custodis from Saarbrücken, Germany, and Stephan Schirmer from Kaiserslautern, Germany. My name is Gunnar Heine from Frankfurt, Germany.
I would like to start, thank you very much also from my side for taking your time for this. Sort of chronological order, I would like to start with the study you presented at the ACC conference last year, the holiday study, if I recall correctly, is the acronym where you tested the acute effect of alcohol consumption on atrial fibrillation. Gunnar alluded to it already. What for us is fascinating is the sort of novel way you designed these studies using rather small numbers of patients with a very sophisticated method. Maybe you can talk us through this a little bit. What was the hypothesis? What was the idea behind it? And how exactly did you actually think about these interesting methods and implement them into practice? And what were the main results of the study?
Yeah, thank you. So they grew out of an experience, well, multiple experiences, but one just as an example was performing analyses of literally millions of patients using primarily administrative data sets and recognizing the limitations of those and of kind of conventional phenotyping of research participants and often relying on ICD-9, ICD-10 codes, for example, and recognizing that that's not really capturing what's going on in ambulatory individuals day to day, moment to moment. Whereas that's, of course, what's of greatest interest to our patients. All of these studies also benefited from direct input from patients and were largely inspired from my experiences in clinic, where patients would ask about the benefits versus risk of consuming alcohol or consuming coffee, and asking about triggers of their atrial fibrillation and what can they do to avoid a discrete episode. So the first study, which yes, indeed, we called the Holiday Monitor Study, involved enrolling 100 individuals with paroxysmal AFib. And again, the goal was to really characterize them in their natural environment. So to try to densely phenotype them, but in a way that wouldn't be terribly inconvenient. So we fit them with continuously recording Zio patches and an ankle device that could continuously monitor for alcohol consumption. We recognize that that could present a bit of stigma walking around with an ankle device. So we put a UCSF cardiology sticker on it so they could say, oh, I'm part of a study, I'm not in trouble. And then we asked them to press the button on the Zio patch, which of course usually is used to timestamp when someone has symptoms, but we told them don't press the button for symptoms. Just press the button whenever you have a drink of alcohol. And then we obtained a blood spot for this chemical called phosphatidylethanol that is only produced in the body when one consumes ethanol. And it reflects drinking over the past 2 to 3 weeks or so. And we found, first of all, that when people press the button, that did seem to be validated by both the phosphatidylethanol as well as the ankle sensor. And every press of the button predicted a heightened risk, about a 2-fold higher risk of a discrete atrial fibrillation episode 4 hours later. Similarly, when we looked at the alcohol concentration inferred from the wearable device. The higher that concentration, either area under the curve or peak concentration, also predicted a discrete atrial fibrillation episode. It might also be worth mentioning in terms of what motivated all of these studies is that the great majority of research related to especially epidemiologic research in AFib has to do with really looking at the first diagnosis of AFib. So who developed AFib versus who did not. And it's much harder to address predictors of discrete atrial fibrillation episodes, which does require kind of an ongoing longitudinal temporal sort of ascertainment.
Well, fascinating. There's a few questions that came to my mind, some more medical and scientific, others more practical. One question is, why is it that it takes 4 hours basically from alcohol intake to atrial fibrillation? What's your thoughts on that? And the other question is, that's more curiosity. How many people did you actually screen? And did you go and look for people that were very willing and also telling you that they do regularly consume alcohol?
Sure. So we screened several hundred, and people were excluded if they didn't drink alcohol regularly, or if they didn't have documented paroxysmal atrial fibrillation, or if they weren't willing to wear these devices for whatever reason. This apparent delay in the timing is interesting, and we still don't completely understand it. We did perform, there's another study where we randomly assigned individuals undergoing AFib ablation to an intravenous ethanol infusion study versus placebo. We called that the Holiday Ablation Study. That was part of the same NIH R01 grant that funded that, as well as the Monitor study. And we did find this acute reduction in pulmonary vein refractory periods, but we didn't find differences in ability to induce AFib between the ethanol group and the placebo group. And one potential explanation was that there's something else going on downstream that takes more time to really generate the AFib episode. So whether that's just a probability sort of phenomenon where you just need to have the correctly timed PAC with this vulnerable substrate, or whether there's something else either related to alcohol metabolites, or perhaps something mediated by changes in autonomic tone, where the vagal effects may be most pronounced a few hours later. We don't know. Incidentally, we empirically selected 4 hours based on a questionnaire to all our participants, where we asked, when alcohol triggers your AFib, about how long do you think it takes? And 4 hours was the median described. Then we did a separate analysis where we just empirically looked at various time points, and it did look like 4 to 6 hours actually was kind of the peak time of AFib after a drink of alcohol. But yeah, we don't fully understand the mechanism by which this occurs, but there does seem to be this delayed effect.
It brings me to the last issue you alluded to in your paper in Annals of Internal Medicine. I think that there might also be effects, obviously, of alcohol on sleep, on other habits that might influence the rhythm situation. What's the clinical relevance? I know this is provocative, but if it's only short periods of AF, does that really matter? Were the patients, I mean, are these people that were, I mean, with 100 people, we probably can't tell, but are they more willing for ablation procedure, for example, or were they really bothered by the episodes?
Yeah, I mean, this is part of the kind of selection bias and limitation we need to acknowledge that's kind of required in order to make this study feasible, right? We had to enroll people who had intermittent episodes that were willing to tolerate those episodes. And so it is important to mention that it may not be completely appropriate to extrapolate to the population. However, I will mention a study that we just published in this new journal, Nature Cardiovascular Research, where we did look at days when people were more likely to drink more alcohol. So we got a data set of breathalyzer measurements from just customers around the world who use this Bluetooth-enabled breathalyzer device. tens of thousands of people, more than 1 million measurements, and we found when do they tend to drink the most? We identified dates that were associated with that, like events that were associated with that, such as certain holidays and other events, the Super Bowl. And then we looked at our database of every ER visit in California over 11 years and found that on those dates, people were more likely to come to the ER with AFib. Not only that, and I think this comes back to your question of the clinical relevance and these kind of short-lived episodes. You know, we often talk about these paroxysmal episodes, but the reality is, of course, people who have persistent AFib, that had to start at some point. Did something trigger that initial episode? It's just impossible to look at repeated measures in a persistent AFib patient. And when we looked at the people who didn't have a previous diagnosis of AFib, they were at a higher risk of an ER visit on those dates, which may suggest that there are a number of people that when they drink, presumably especially in excess, that they are putting themselves at risk for even a first AFib episode.
So before switching to the second study, I would just briefly like to remark what I found very striking. It's not about binge drinking on holiday, it's really just one drink that causes this tremendous increase in AFib episodes. So one glass of beer or something like that, actually.
Yes, and this also gets to another tricky, nuanced, and very important issue, which is the net benefit versus risk of light regular drinking, such as 1 drink a day. And this, I think, is an especially important place to emphasize that these were paroxysmal AFib patients, so people who already established an AFib diagnosis. And yes, it did appear that in that population, even 1 drink was enough to trigger an atrial fibrillation episode. A major unknown is what about the general population that does not have a diagnosis of atrial fibrillation, given this other evidence that light regular drinking may have some beneficial effects on coronary disease, on diabetes, and even some cancers, leukemia, lymphoma, for example. We actually just put in a grant to conduct a major, large randomized trial of light drinking versus abstinence. We hope that the reviewers will be favorable and help us conduct that study, but we would love to do that study.
That would be just fantastic. I think people in Israel once tried it actually to start such study, but I think they ran short of funding and they had to stop this study. But surely that's the study everybody would wait for. Now, the second study that we aim to discuss tonight is the I-STOP-AFib study. And this is one of the most sophisticated clinical studies I have ever read. So the patients that were recruited were quite similar to those who participated in Holiday, if I got it right. But this time, this was not a prospective cohort study, but you randomized patients into 2 groups, and then it gets somewhat complicated. So we need your help here to explain us what happened to these people.
Yes, a very complicated study, which, by the way, informed the CRAVE study, which was very deliberately very simple, having learned a lot from the I-STOP-AFib study. So yes, indeed. So this incidentally was completely remote. So the Holiday study was in person, patients at UCSF. We met them in person, we fit them with devices. I-STOP-AFib was using a digital research platform we've developed at UCSF called Eureka, which is designed to help facilitate any investigator interested in mobile health-based research. We recruited paroxysmal atrial fibrillation patients remotely. A major inclusion criteria was they had to be interested and willing to test a trigger, but that trigger could be whatever they wanted to test. They were then randomly assigned to just track their symptoms for several weeks versus undergo their own N of 1 trigger testing. The individuals randomly assigned to the trigger testing received a menu of here's some potential triggers for you that you can test. We derived that menu from a survey of about 1,000 AFib patients previously to ask them, what do you think triggers your AFib? And so alcohol, caffeine, certain exercises, laying on your left side, dehydration, etc. If their particular trigger was not on that menu, they could write it in, they could free text it in. Then they were randomly assigned in 1-week blocks for 6 weeks to this is your week to test your trigger. You told us that 2 glasses of red wine trigger your AFib. Versus On the off weeks, make sure you avoid all alcohol this week. Every day we asked them, did you have any AFib yesterday? We also sent all participants, whether in the tracking arm or the N of 1 testing arm, AliveCor cardiomobile devices, which, as many of your listeners may know, are these smartphone-based ECG devices that enable one to record a single lead EKG. The primary outcome was a validated questionnaire called the AF-EQT that summarizes AFib-related quality of life at the end of that session. Then, incidentally, so that there was a kind of an initial study period that was 10 weeks. At the end of that 10-week period, whether the people were initially randomized to tracking only versus testing their triggers, they were thanked for their participation, and then they were asked, do you want to test another trigger? And so the folks in the tracking arm were also invited to test a trigger if they wished. So we did look at, the study had multiple layers. The kind of primary outcome was the AF-EQT, where we found no difference between those randomly assigned to trigger testing versus tracking only. Importantly, in the trigger testing, they tested their trigger, as I mentioned, for 6 weeks. Then they had a month to kind of respond to the information that they gleaned from that trigger testing. They received their results. So they were told there's a 78% probability that your trigger, caffeine, triggered your AFib. And then they had 4 weeks to kind of respond to that. When we looked at the number of reported AFib episodes in those 4 weeks among those undergoing trigger testing, compared to the folks that are just tracking their AFib, not learning anything about their triggers, the people in the trigger testing arm did report less days with AFib compared to the tracking only folks. Then another layer of the analysis was to do a meta-analysis of all triggers tested, whether it was in that first study period or subsequently, and we looked at the individual types of triggers that were selected. And the most commonly selected trigger was caffeine. And we could find no evidence that caffeine was associated with a heightened risk of, again, a discrete AFib episode. In contrast, when we looked at alcohol, those who selected alcohol did experience more self-reported AFib when randomly assigned to alcohol compared to not.
So I would also have 2 or 3 technical questions, because it's so important, I think, to understand this study properly in order to really realize the importance which is in it. So do you have any information whether these people who chose to test alcohol reduced actually their alcohol intake from week 7 to week 10? Because these were the guys who really had a drop in their AFib episodes after the off and on weeks, if I got it right.
We did not ascertain exactly how much alcohol they consumed, so it's a great question, but we were unable to demonstrate or really examine whether there was a reduction in alcohol consumption to explain that difference that we observed.
And then, as in every study, I think the intention to treat data are less convincing than the per protocol data. Therefore, I would have another second technical question. So if a patient reported to have a drink on Monday and Tuesday, and he did not drink anything on Wednesday, and he did not report any data, as some people actually didn't give you data all the days, so the compliance was not 100%, right. Would you then go on a day per day basis for your per protocol analysis, or did you in this case just skip the whole week and restart with the next week then?
Yeah, great question. And this relates to missing data, which was indeed an issue and a limitation very important to acknowledge in this trial. Part of that was exacerbated by the fact that it was completely remote. So we didn't have the benefit of research coordinators really hounding our participants on a regular basis. So indeed, the findings were most robust in the per protocol or as treated analysis, which relied on the report of consumption. The benefit being that it was fairly real time. We were asking every day, so that should mitigate against recall bias. On the other hand, they certainly did not answer every day. And so we essentially assumed, we just, if they didn't report anything, we didn't analyze that day for the per protocol analysis. So we only examined the days when they answered the question and then compared the days when they said, yep, I consumed alcohol versus no, I did not consume alcohol.
And then one last question before switching the mic then to Florian. Why did you choose quality of life as an endpoint? Because it's somewhat a pity, it's so such a strong study, but formally is kind of a negative endpoint. So why did you not just go for reduction in AFib episodes when designing the study?
Yeah, it's a very good question and fair question. I think we wanted to use a validated instrument, and we worried about that sort of the day-to-day adherence, and wanted to have a single endpoint that could encompass, and incidentally, that survey instrument is designed to encompass the previous 4 weeks. And that is something where we did utilize clinical research coordinators to call people. So we were able to supplement in that sense. So we weren't, so, you know, relying completely on the day-to-day would really require a lot more resources, frankly, rather than calling people to say, hey, can you please complete this AFEQT single questionnaire? So it was primarily a question of feasibility. I think given more resources or funding, we ideally would have used a continuously recording ECG device in an ideal world. The other reason was that ultimately there's an argument to be made that the clinical relevance of the presence versus absence of atrial fibrillation, especially in people who already have a diagnosis. So we already know they have atrial fibrillation, that ultimately what we care most about is their quality of life and how they're feeling and how functional they are related to their atrial fibrillation. It's not as if we would say, you know, we're going to stop anticoagulation, for example, because at least not in a few hundred patients testing these triggers, right? So what we thought would be the most clinically applicable lesson would be to help inform how to influence quality of life for these patients.
So great, and you just walk us through CRAVE, our last study today, and ask the question: is coffee good for your health? And you tested, or you did the first kind of randomized trial to investigate the real-time effects of coffee on risk for arrhythmia, but not only on arrhythmia, but also on sleep, on step counts, and on glucose. And could you just walk us through the fact it's not quite clear what is the risk or even the benefit of coffee, and what was known before your study, and what was the rationale to investigate that?
Yeah, so part of the reason I find investigating both coffee and alcohol so interesting is because, number one, they're both so ubiquitous. Number two, they're under our control or our patient's control. They can decide whether they're going to consume these substances or not. And number three, I think most compelling, is there may be some benefits, there may be some risks. That probably varies from individual to individual, and maybe depending on how much we consume. For alcohol, I should mention, no doubt if one consumes in excess, that is overall more harmful than not. So in terms of background regarding coffee, there's this conventional wisdom that coffee triggers arrhythmias. But when you look at the literature, there's some evidence in favor of that, but there's also quite a bit of evidence contrary to that. You know, we tend to think of increased sympathetic tone or catecholamines as enhancing arrhythmias. But more recently, we've come to recognize that atrial fibrillation, for example, can often be vagally mediated, which may suggest that enhancing sympathetic tone might not be such a bad thing. We recently published a study where we analyzed data from the UK Biobank, published this in JAMA Internal Medicine, and we just looked at baseline coffee consumption as reported by those participants and incident arrhythmias. And we looked at all arrhythmias. They rely on ICD-9, ICD-10 codes, and we actually found a reduced risk of arrhythmias among people who consumed more coffee And that seemed to be driven largely by atrial fibrillation. That is consistent with some other cohort studies. But at the same time, you can find evidence of increased PVCs associated with coffee consumption, but all of these things are very prone to confounding because they're not randomized experiments, but rather they're simply what do people tend to do and then what happens to them. And of course, there are going to be differences in those who tend to consume more or less coffee that even the best multivariate adjustment isn't going to be able to fully address. So that largely motivated our study. Number one, in the hopes of doing the first randomized trial so that we might infer causality. Now, there's also evidence that those who consume more coffee experience a lower risk of diabetes. And the reason for that is completely unknown. Some people wonder if that's because under the influence of caffeine, individuals are more motivated to exercise, for example. There's also some mortality benefit. But again, maybe that's all confounded by the type of people that tend to drink more coffee, higher educated, people who can afford to drink coffee, for example. So in CRAVE, we randomized, we enrolled 100 volunteers. We fit them all with a continuously recording Zio patch, a wrist-worn Fitbit that could record step counts as well as quantify sleep, which was another major outcome. We had them wear continuous glucose monitors. And then we used a geo-tracking app using our Eureka digital research platform to look at how their geolocation changed over time. And then we also obtained DNA and genotyped them for caffeine metabolism related genetic variants. Then they were randomized, and this will sound a little familiar from I-STOP-AFib, but as I mentioned, this was much more straightforward. So everyone was just, this all had to do with coffee. They also were generally healthy individuals, and we had them all wearing these continuous sensors. And then they were randomized day to day for 2 weeks to consume coffee versus avoid all caffeine. The way the randomization actually worked was we took blocks of on-off versus off-on days to assure they never had more than 2 days, either on or off, because there could be cumulative effects. For example, if we completely relied on randomized days, they could have had 7 days on and 7 days off. And we really wanted to tease out the acute effects. That also helped with our power. So even though it was only 100 people, it was also for each person, we had 7 days or 7 experiments on and 7 experiments off. So that really enhanced our power, especially because we're looking at differences within individuals where the variance therefore is substantially reduced. So jumping to what we found. So and we did distinguish between intention to treat, so what they were assigned to versus per protocol or as treated, which is what they actually consumed. Now, a common question is, well, how do you know they followed your instructions? And how did you ascertain whether they actually consumed coffee or not? So we did that in multiple ways. So one, taking a page from the Holiday study, we had them press up the Zio patch button whenever they had a drink of coffee. Because that was real time and because they were not incentivized to lie, we think that should have been fairly reliable, although we did test that in ways I'll describe in a moment. Then every morning we asked them, did you actually have any coffee yesterday? And if they said yes, then we asked, how much coffee did you have? Third, we actually reimbursed them for all coffee purchased as they gave us a receipt that was date stamped. And we told them, we will pay for your coffee even if you weren't supposed to have consumed it that day. And that way we could really line up those receipts. And then finally, we used the geolocation tracker to look and see, did they more often visit coffee shops on days when they were randomly assigned to consume coffee? And the compliance with their instructions were not perfect, but in every case, they were much, much, much more likely to consume coffee on the days they were instructed to do so by all of those metrics. So But we did perform analysis, intention to treat, meaning as they were randomized versus per protocol, meaning, and we really relied more on the Zio patches, which we thought was the button presses to tell us, to examine, okay, if they had a cup of coffee, what actually happened with all of these various measurements. So in intention to treat, we found no differences in premature atrial contractions, but in as treated, so the number of coffee drinks actually consumed, that was associated with statistically significantly less premature atrial contractions, which we think is very interesting and consistent with the literature that those who consume more coffee may experience less atrial fibrillation. We had previously published a paper where we looked at a community-based population. This was also published in the Annals of Internal Medicine, and we showed that people with more premature atrial contractions were more likely to develop AFib. We also know that in AFib ablation procedures, or we think there are some individuals who have PACs arising from their pulmonary veins, and if we can isolate the pulmonary veins and rid them of those, we can rid them of their atrial fibrillation. So perhaps some evidence in favor of a protective effect on at least atrial arrhythmias. In contrast, in both intention to treat and per protocol, consuming coffee was associated with more PVCs, which also somewhat fits with past experience. The most robust findings were related to step counts and sleep. So whether it was per protocol or intention to treat, consumption of coffee was associated with a very highly significantly increase in step counts on those days, on average about 1,000 more steps on days when people were randomized to coffee. And then for every coffee drink consumed, it was about 500 more steps per day. In contrast, on the more negative side, on days randomly assigned to coffee, people slept on average per objective measurements from this Fitbit about a half hour less, and per coffee drink was about 15 to 17 minutes less sleep per coffee drink. The glucose measurements, we found no relationships. Then when we looked at the polymorphisms that affect caffeine metabolism, the thing that made the most sense was the slow metabolizers were especially prone to reduction in sleep associated with coffee consumption. Whereas interestingly, the fast metabolizers exhibited no relationship between any reduction in sleep and coffee consumption. The only other interaction with the genetic polymorphisms had to do with premature ventricular contractions, where here, this is a little backwards, and so we're still trying to puzzle this out. But it appeared the faster metabolizers experienced the greatest increase in PVCs when consuming coffee. And we can talk about why that might be. Of course, could be a chance finding, but it was pretty robust and consistent.
Okay, great results. If I get it right with referring to certain biases, and so if I get it right from your presentation at the AHA, your patients in the study were rather fit, rather young, and 50% were female. Could you comment on that? How that could maybe have affected the results?
Yeah, so the age range which we presented really as a mean and standard deviation didn't fully capture the breadth of the age range we included. We had individuals from pretty much every decade of life, from the 20s even to the 80s. And I think, and I should also mention that the first two studies we've talked about have been published manuscripts. CRAVE I've presented but has not yet been published. And I think in the publication, I will include a table with decades of life and number of people from each. But yes, they were certainly not sick individuals. They were generally healthy. They were a bit young. And also importantly, these were not individuals with especially high PAC or PVC counts. And so it may be, for example, if we take someone with a high PVC count, that PVC is just going to fire, and it doesn't really matter whether they're consuming coffee or not. So we do need to be careful to extrapolate these to other populations beyond the healthy population.
Okay. Okay, one last question just to conclude. If you had to put it in 1 or 2 sentences, how healthy is it to drink coffee?
Yeah. So in one sentence, I would say it's complicated. I think that this demonstrates there are pros and cons, that it's not a panacea, but it's not overall harmful. And that, I see our job as informing the public and clinicians and our patients. Here are the pros and cons. Here are the trade-offs for you to consider. I think, one of the things we hope to highlight in these sorts of N-of-1 studies is in fact the heterogeneity between individuals. Different people have different priorities, they have different propensities. And so it's working in partnership with our patients to understand, is this someone suffering from insomnia? Where then we can point to this objective evidence, randomized evidence that, yeah, coffee really does reduce your sleep. And, that can be quite profound and clinically meaningful. On the other hand, someone who's having a hard time getting motivated to exercise and they enjoy coffee, especially those, I should mention, this seems to be fairly common. People I see in clinic with AFib, for example, that have been told by some practitioners, stop all your coffee. I think that is not warranted, certainly not a kind of a universal blanket recommendation for our arrhythmia patients, for example, might be causing more harm than good. And we have to weigh that on the individual patient-to-patient basis.
Should we be concerned by the increase in ventricular arrhythmia? Do you think that this might be of concern?
Yeah, so I think it can be, and we now recognize, the kind of the perspectives on the clinical relevance of premature ventricular contractions have fluctuated over the years, and especially in cardiac electrophysiology, we've come to recognize that they can be a risk factor for heart failure, and we think that that's at higher burdens. We don't know exactly what that threshold is, but that is a consideration. And again, it's part of the pros and cons. As mentioned, this may not be applicable to those with a high burden of PVCs, but I do think it suggests it's worth a trial. I wouldn't say, again, there should be a blanket recommendation to avoid coffee in everyone with PVCs, but if someone has symptomatic PVCs, they're bothered by them, or they have a high enough burden that we would worry about the development of heart failure, it's certainly reasonable experimenting, stopping coffee, checking in with the patient regarding their quality of life, and redoing, for example, a continuous ECG monitor to recheck their burden.
So I have a very last question. So these data are just so fascinating. Have you already been approached by family members, by friends, by peers who told you that because of all your studies, they reduced their alcohol intake? Because actually I kind of did after reading these papers.
Interesting. Yes, indeed I have. And I get emails from people from all over the world that will share that with me, especially AFib patients who have reduced their alcohol intake. And then some who have said, oh, I now enjoy my cup of coffee because of this research. And I've also taken that to my clinic as well. And I have some, for example, as I just mentioned, atrial fibrillation patients. And I wouldn't recommend starting coffee per se, but if someone enjoys coffee, they're not drinking in excess, there's no evidence that it's caused harm in them, I tell them it's fine to enjoy your daily drink of coffee.
So thanks a lot. Sorry.
I have a pathophysiological last question, trying to looking for a bottom line, because you alluded to the vagal activity thing. If we say, okay, coffee activates sympathetic tone and alcohol maybe does the other part of it, is it that paroxysmal atrial fibrillation, at least the populations you studied, is mostly vagal AFib? And is that in otherwise rather healthy persons, because that's what we have here, is that the most important trigger?
I don't know. And it's problematic because generally we think of vagal tone as a healthy thing, and people with more sympathetic tone is perhaps harmful. So it's a little contradictory to how I think we think about certainly general cardiovascular health. It's a little tricky. And now it's true that in the Holiday study and in I-STOP-AFib, we were looking at paroxysmal atrial fibrillation patients, but most of the coffee work thus far, at least, has really been in the general population and looking at the development of AFib. And then in CRAVE was in quite healthy people and looking at PACs. But CRAVE may also be a mirror into the pros and cons of this heightened sympathetic tone with more PVCs, maybe less PACs, less sleep, more physical activity. And you know, I recognize that we all want a kind of straightforward, here's the one answer, this compound does one thing, but the reality is these are, you know, complex effects, which is why they're so interesting to study.
So we hope that you will get funding for this large study that will finally answer the question on the long-term implication of alcohol intake. Until then, again, we are so fascinated by reading the papers you have published so far. We're looking forward to reading the CRAVE study in the next weeks or months, hopefully. We will have some other videos on atrial fibrillation in the weeks to come here on our channel. And thanks a lot for taking the time for being our guest tonight. Have a nice evening in San Francisco, and hopefully looking forward to meeting you once again. Thanks, Greg.
Thank you.
Bye-bye.
Bye. Thanks so much. That was fun.